DSW 2310, Dual Diagnosis, Treatment and Assessment, Trauma and Stressors Related Disorders, Chapter 12. Trauma. We all experience stress. Some of us have or will experience trauma. 39 to 75% of the general population have dealt with at least one trauma. Trauma can include a person's reactions to the life event. Trauma includes assault, rape, abuse, accidents, criminal victimization, catastrophes, bullying, natural disasters, etc. Witnessing events or hearing about traumatic events can be traumatic. Trauma can be physical and/or psychological. Persons with developmental disabilities experience more adverse life events than the general population. We all cope differently. Some develop a mental illness called post-traumatic stress disorder, PTSD. PTSD is an anxiety-related disorder. Prevalence: 3.5% of general population experience PTSD. 8.7% lifetime prevalence of PTSD. 3.5 to 23.6 of emergency services personnel who are exposed to traumatic events and those who survive personal violence experience PTSD. Those institutionalized. Rate of physical or sexual abuse in adult men is 60%. Rate of physical or sexual abuse in adult females is 80%. Recent study shows that 16.5% with a history of abuse diagnosed with PTSD. In 2003, 35% of those who suffered sexual abuse had PTSD. Post-traumatic stress disorder results from severe trauma, relive events, mental illness with a specific trigger. Not all people who have experienced trauma develop PTSD. Biopsychosocial model is applicable. Symptoms of PTSD fall into 3 clusters: re-experiencing the trauma, avoidance of trauma reminders, increased arousal. Important: if these symptoms are experienced within 3 days to 1 month after the event, and the symptoms last from 3 days to 1 month, then the diagnosis is acute stress disorder. PTSD can appear at any time after the trauma and does not disappear. It lasts over time, chronic. Experiencing the trauma. Flashbacks or nightmares. Intense feelings of pain, terror, panic, etc. can be experienced years later. Re-experiencing may result in high-risk behavior or becoming an abuser themselves. Avoidance of the traumatic reminders, anything, smell, object, noise, person, etc., that may trigger a flashback. Emotional avoidance, shutting down or emotional numbing, withdrawal. Difficult to build relationships. Hyperarousal, hypervigilance, and extreme awareness of everything that is happening in the environment. Comorbidity. Other symptoms can include dissociative states, panic attacks, aggression, violence, poor impulse control, depression, hallucinations, anxiety disorders, often misdiagnosed as borderline personality disorder or dissociative disorder. Criteria for PTSD DSM-5. Symptoms of PTSD in persons with developmental disabilities: fear, screaming, crying, moaning, severe nightmares, cringe around people, sleep under bed, wearing layers of clothing at bedtime, terrified facial expressions, hiding, defensive covering of body. Hypervigilance, startles easily, constant watching of others, keeping one's back to the corner. Self-mutilation, aggression, fight to get away. Non-compliance, refuses to go to certain places, be with certain people, participate in certain activities. Hallucinations, reliving trauma. punching and screaming at imaginary people. Eloping, avoiding triggers by running away. Nightmares, aggressive, inappropriate sexual activities toward others under inappropriate circumstances such as strangers, fondling strangers, exposing self to public. Exercising caution. We run the risk of misunderstanding these symptoms as behavior if we do not know about the trauma, may result in misdiagnosis such as schizophrenia, intermittent explosive disorder, adjustment disorder, etc. We do know that rates of physical and sexual abuse was high in institutional settings. Factors contributing to incorrect diagnosis: limited verbal skills, inability to describe emotions or inability to recognize different emotional responses, incomplete histories, different staff, no documentation, symptoms that mimic those of other mental illnesses, flashbacks, hallucination, disbelief about the stories, savage, inhumane treatment of the vulnerable, professional reluctance to hold others accountable, to stir up trouble, for fear of retaliation, lack of understanding about the nature of trauma for people with developmental disabilities, losing staff, moving away from family, being hospitalized or institutionalized, believing they are not really affected by it. They are disabled. How do they know they are being abused? No normal emotional reactions. Education and advocacy, a rights-based approach. We must raise awareness with regards to the frequency of PTSD for people with developmental disabilities. Key diagnostic indicators: appearance of being psychotic, transient periods of spacing out, fearfulness in specific situations, clingy, needy behavior, acting out an attack, aggression if forced into anxiety-provoking situations that trigger flashbacks. Treatment. Medications. Treat symptoms of PTSD and concurrent disorders, depression, anxiety. Right clinical therapy, cognitive behavior therapy, exposure therapy. Psychotherapy, personal interaction to help support the person in working through PTSD. Habilitation, make environmental changes to eliminate triggers. Education and support for staff to recognize symptoms of PTSD and pursue appropriate treatment. Support, maximize safety. Don't force person to confront the perpetrator. Remove triggers from the environment. Allow person to use own coping mechanisms. During flashbacks, anchor person in the here and now. Support the person by talking about it. Teach the person how to handle stress. We need to be compassionate, empathetic, understanding, supportive, caring, and we need to respect rights.